Hey guys, welcome back to my channel. This is Dr. Shubham, and today I'm gonna talk about a very important topic and a very common topic which you will be seeing in your hospital duties. So that is the pleural tuberculosis. So let's try to understand and let's dive into this topic, which is very interesting and very common yet. So before going into the pleural tuberculosis, let us just revise about the tuberculosis. That this is the very common burden, I would say, over our country, and most of the cases which we are seeing, uh, you know among those cases, tuberculosis cases are very common. So tuberculosis is a very it is a very wide subject in itself, and if we broadly classify the tuberculosis, then we shall say that we are having two kinds of tuberculosis. One is the very common one, that is the pulmonary tuberculosis, which is involving the lungs, and on the other side we are having the extrapulmonary tuberculosis. So pulmonary tuberculosis, on one hand, if you say that we are having two kinds of people or the patients, we can say. The one is having the pulmonary TB, which we are writing in a short as PTB, pulmonary TB, and on the other side we shall classify other patients, right, which are usually where the lungs are not covered, that is the extrapulmonary. So we are calling that as EPTB, right, that is the extrapulmonary TB. So extrapulmonary means outside the lungs, right. So that is the extrapulmonary. Now this TB can be involving anything. It can involve the outside of the pleura, that is the outside of the lungs, that is the pleural TB, or it can be the lymph node TB, it can be the skeletal TB, it can be the cutaneous TB, it can be the pericardial TB. There are many kinds of organs which can be affected by the tuberculosis, and there is also a myth that if the person is having tuberculosis, then it has to be the pulmonary tuberculosis. However, most commonly the tuberculosis is involving the lungs, but this is not the same story in all the patients. So that is about one thing. Now let me just come into the pleural tuberculosis. So pleural tuberculosis is coming in the extrapulmonary TB. It means outside the lungs. We know that pleura is covering the outer layer of the lung, so it is outside the lung very well. So if somebody is having the pleural tuberculosis, we will not call that as pulmonary tuberculosis. Rather, it is coming under the category of extrapulmonary tuberculosis, that is the EPTB. So that is the first point which I wanted to highlight over here, right. The next thing is that if we talk about the pleural tuberculosis, so this is one of the very common type of extrapulmonary tuberculosis. However, the most common extrapulmonary tuberculosis, or we say that what is the most common type of TB in the category of extrapulmonary TB, then the answer would be the lymph node TB, right. So here I would like to highlight some points over here. So pleural TB is actually, this is the leading cause of exudative pleural effusion in our country. Okay, so we'll talk about later on that what about the exudative and the transudative pleural effusion. So if we talk about the pleural effusion, we are having two categories, that is, one is exudative and another one is the transudative. So in the exudative pleural effusion, there are many etiologies, many diseases which can cause the exudative pleural effusion, and there are some diseases which can cause the transudative pleural effusion. So there is a long list over there. We'll talk about that in some other class, but over here let me tell you, pleural tuberculosis is the one of the type of the exudative pleural effusion, or I would say one of the leading cause of the exudative pleural effusion, right. Now this point I was highlighting, that lymph node TB, while lymph nodes are the most common extrapulmonary site involved. So in the extrapulmonary TB, the most common TB is the lymph node TB, and then comes your pleural tuberculosis. So pleural involvement is the second most common over here, right. So that is one point. Now we had talked about that there is a two kinds of classification, that in the classification we generally read there is a pulmonary TB or the extrapulmonary TB. So as compared to the pulmonary TB, the pleural TB is affecting the younger age group, while the pulmonary TB is affecting mainly the older age group. But here the younger population is targeted by the pleural TB, and you can see that pleural TB is most commonly affecting the younger population, that is the 20 to 40 years of age very commonly, right. and higher incidence is found in the diabetic population. So diabetic population is the major risk factor for many diseases, but one of the major risk factor for the pleural tuberculosis also. So till now what I have talked about is that tuberculosis is broadly classified into two types. One is the pulmonary TB and another one is the extrapulmonary TB. In the extrapulmonary TB, we have read that lymph node TB is the most commonest site of the extrapulmonary TB. After that comes your pulmonary tuberculosis. Okay, not the pulmonary tuberculosis here, rather I would say pleural tuberculosis. Okay, so pleural tuberculosis, right. Diabetic population is the major risk factor for the pleural tuberculosis. Younger age group is the target for the pleural tuberculosis, and here we can see the X-ray of one of the patient, where we can see that on one side, that is, this is the right side of the patient and this is the left side of the patient. Here also they have mentioned about the left side of the patient is in this side, but however, so here in the left side, this is called as the CP angle, which you can see over here, and here we can see that CP angle is much clear, and if we compare it on the with the other side, that is the right side, here we can see the right sided CP angle is obscured. So that is something which is telling that there could be some amount of fluid which is obscuring the right CP angle or the right costophrenic angle, and here we can see that this kind of sign which we can see over here, this kind of thing, that is the meniscus sign, which we can appreciate over here in this particular chest X-ray or chest radiograph. Okay, so here we can see that there is some homogeneous opacity which is obscuring the costophrenic angle, right sided costophrenic angle, okay, suggesting that there is right sided pleural effusion. Obviously, by looking at the X-ray, we can't say that it is the pleural tuberculosis or it is something else. Just chest X-ray just tells us that there is some kind of fluid which is obscuring the CP angle. It can be the right side, it can be the left side, or it can be both the sides also. Okay, so that is a thing which we need to talk about. The next thing is how we can say the pleural tuberculosis. Will come to that. Actually, we need to we need to do the pleural tapping. We need to remove the pleural fluid from there and send it for the diagnostic purpose in the lab, and then we will be able to know about it. So how this pleural fluid is actually getting accumulated over there, or what is the pathophysiology basically behind this. So what is the cause of accumulation of the pleural fluid over there, excess amount of pleural fluid over there. So they say that there is a delayed hypersensitivity type phenomena which is actually causing the accumulation of fluid over there. Then there could be the rupture of subpleural foci. So here we can see that this is the pleura, right, this is the pleura. Okay, so we know that there is a parietal pleura and the visceral pleura. So this is the parietal pleura, this is the parietal pleura, and this one is the visceral pleura probably. Okay, so here what we can see is that there is some kind of subpleural foci. Okay, there is some kind of subpleural foci which we which can rupture, actually, which may rupture. So here I am showing that these are some of the subpleural foci. So if they will rupture, then obviously some amount of fluid can actually come through this subpleural foci into the pleura, and if they will be coming into the pleura, then obviously they can disrupt the physiology over there. They can actually cause many kind of inflammatory reactions over there, many kind delayed type of hypersensitivity reaction might be causing over there, and that is causing the pleural fluid accumulation, excess amount of pleural fluid accumulation over there, right. The next thing is that there could be the contiguous spread from the lung also. For example, there could be some lesion in the lung or some kind of pathology in the lung that can also contribute to to the pleural TB. I mean, the excess amount of fluid can be accumulating in the pleural space due to some kind of pulmonary nodule or some kind of pulmonary pathology as well, or lesion as well. Then there is the hematogenous or the lymphatic spread can also cause this particular pleural effusion, and which is lastly the pleural TB, right. Pleural TB, by how we can say the pleural TB, we'll know about the diagnostic algorithm later, but we need to tap the fluid, and if it is coming or suggesting the pleural tuberculosis, then we can say that, right. About the clinical features, guys. So about the, what about the clinical features? So clinical features are very common, just like any other TB over there. So the very common symptom which we generally see in these kind of patient, that is the coughing. Okay, so almost 94% of the patients, they are complaining about the coughing, followed by the chest pain. Around 78% of the patients, they are complaining about the chest pain. Then fever, around 66% of the patients, they are complaining about the fever. And then there could be the SOB, that is the shortness of breath can be there. Along with that, some constitutional symptoms can be there. For example, they will be complaining about the night sweat, which is a very peculiar feature of the tuberculosis, right. Then night sweats, they might talk about the they might talk about the weight loss, which is also a very characteristic feature of the tuberculosis. So features are almost common. There could be cough, there could be fever, there could be chest pain, there could be shortness of breath, there could be weight loss, there could be the night sweats. So these are the very common symptoms which obviously we need to look for while taking the history from these kind of patients, right. So what are the differential diagnosis in your mind? What should come to your mind as far as differential diagnosis are concerned whenever you are seeing the pleural effusion case? So in the pleural effusion, we are having various kind of diagnosis which we need to keep into mind. So for example, one is the malignant pleural effusion, right. Then there could be the empyema, there could be the fungal related effusion, right. There could be the chylothorax, hemothorax, liver abscess, okay, sarcoidosis. There could be the SLE or the rheumatoid pleurisy, okay. But these later ones are not the very common one, but obviously the first 3 or 4, they are very common differential diagnosis which we need to keep into our mind, right. Okay, now coming to the diagnosis part over here, we are having 2 important modalities which we can use in the form of imaging for diagnosis of the pleural tuberculosis. So for example, in your hospital, some patient comes to your hospital and they are complaining about these kind of symptoms which we just now talked about, that there is this fever, shortness of breath, chest pain, coughing, night sweats, and loss of weight, etc. So there and you saw the so what investigation will you do over there? So very common and mandatory for such kind of patient, that is the chest X-ray. So we should be doing the chest radiograph over there for sure. So we will be doing the chest radiograph, okay. So in the chest radiograph, what we can expect? So use in all such patients, we should be doing the chest X-ray. That is very important. Now what is the advantage of doing that? Advantage is that if there is a the pleural fluid, if it is more than 200 ml, then we can easily detect it on the chest X-ray posterior anterior view, okay, PA film. Pulmonary involvement can be seen and progress can be monitored with the chest X-ray. What is the disadvantage? That there could be some radiation exposure and small amount of fluid, it can be missed in the chest X-ray, because if at least 200 ml of pleural fluid should be there to appreciate on the PA view chest X-ray, okay. So that is also very important, which we need to keep in mind. Sensitivity and specificity, if we concern, then if we are taking the chest radiograph in the supine AP position, then sensitivity is 33 to 92% and the specificity is 70 to 90% or 89%. Lateral decubitus position, always remember, it is able to detect a very small amount of pleural fluid. So sensitivity is 94% and specificity is almost around 100%, right. So even if in some patient you are seeing in the lateral decubitus position there is a pleural effusion, then definitely this is the 100% specificity. It is showing that almost it is clear that this patient is having the pleural effusion. In the upright PA view, 82% good sensitivity and the specificity 81%. Upright lateral again 86% and the 88% is the specificity over there. So after the chest X-ray, usually we are doing the ultrasound as well. So ultrasound is in the selected patient, but chest X-ray is mandatory for all such patients. Ultrasound can be plus or minus. That ultrasound you shall do or you shall not be doing, depends on the facilities available or not. That is also the issue. So ultrasound, in the ultrasound you will be seeing the anechoic region. If it is black in color below the pleural line, that is called as the fluid basically. So in the ultrasound you will be seeing the black color of picture. So that is the fluid basically. So in the selected patient will be doing that. This is the bedside investigation which can be done, and it can detect as little as 50 ml of pleural fluid in the pleural space, and septations might be visualized through the ultrasound, and there are no chances of radiation. So in the chest X-ray there is bit of radiation exposure, in the USG there is not. USG can be done bedside, however chest X-ray can also be done like portable chest X-ray, but the films are not that good as compared to the PAV. Obviously in the chest X-ray we are not appreciating the septations well, in the ultrasound we are also appreciating the septations well. What are the septations over here? So in the septation I would like to say over here, for example, if this is the lung, okay, so here was a picture as well. Yes, if this is the lung and there are some septations, so septation how they will look? So septations are something looking like this, okay. So there could be some septations like this, and in these septations they can be visualized from the ultrasound but not in the chest X-ray obviously, and there could be some fluid inside it. There could be some fluid inside it which is very difficult to drain actually. Why it is difficult to drain? Because if you are putting the needle inside the pleural space, so your needle will go into one of these pockets, right, and then you will empty out that pocket, but what about other pockets? So it is impossible for us that we will be pricking the patient so many times and to drain out those pockets. It is not practically possible, right? So that's why this is a bit of difficult. If the patient is if some patient are having the septations inside the pleural space, then it is a bit difficult to break that septations and all of these things. However, we are having other methods also by using the streptokinase and all other things, but that will be discussed in another class. So for now we know that there could be the chest radiograph which can be done, mandatory for all such patients, and ultrasound we can do as well, okay. So lung involvement cannot be ruled out in all the cases. That is the disadvantage of the ultrasound. Sensitivity is very good, 90 to 94%, and specificity is even more good, that is the 93 to 100%. And usually whenever we are draining the pleural cavity, we are doing it under the ultrasound guidance only, right, in this era. Now what about the pleurocentesis? Pleurocentesis means you are draining the pleural fluid from the pleural space, right? It could be left side or it could be right side also. What are the precautions which we need to keep in mind while doing the pleurocentesis? Very important question. So here we need to keep in mind that platelet count should be more than 50,000 because you are gonna prick the patient. So if the platelet counts will be very low, then there would be difficulty in stopping the bleeding over there. Check for the clotting abnormalities, for example, check for the PTINR or APTT and all, okay. That is very important because we are pricking the patient, so it helps us in the in getting the idea that how much time the patient might take in stopping the bleed. About whenever the patient is having severe coughing or the hiccups basically, then also we should avoid the procedure at that point of time, and we should be waiting for the patient to get stable, right. And about the procedure, guys, how to do it. So before doing any kind of procedure, we should be taking the consent from the patient and from the family members of the patient, and we should make sure that we explain the procedure well to the patient and the family members, so that they are very comfortable with the procedure as well, and they will be well aware of the procedure, that what is going to happen with them. So that is very important. The first thing is consent is very important, which we need to take and explain to the patient and the patient family members as well, right. Second thing about the position is very important. So we should be doing the right positioning of the patient. So how to do the positioning of the patient basically? So we will be asking the patient to put the arms which are resting on the elevated table basically, and the patient will be putting his hand at the upper chest level, so that you are gonna prick the patient from posterior side of the patient, right. So by doing this, I'm talking about this position, this particular position. As you can see, by doing this, what we can see is that we will be appreciating the intercostal space very well. So that is also the thing basically. So what we will be doing is that we will be, for example, this is the area, we will be checking this area with the ultrasound. First of all, we'll do the ultrasound basically, and in the ultrasound we did the chest X-ray already. chest x-ray we saw that, for example, this is the right sided pleural effusion. We'll do the ultrasound, then we'll doing the ultrasound we'll mark the site of the pleural tapping, and after marking the site, we'll again check that with the ultrasound probe that whether we have marked it correct or not, and then finally we shall proceed with the procedure. Okay, so that is the procedure basically. So after before pricking the patient, we should always tell the patient what we are going to do with them. Then positioning the patient, upright sitting position should be taken by the patient so that we can appreciate the intercostal spaces very well. Then site of insertion, you will be checking with the ultrasound probe that whether it is correct or not. Then usually we are pricking the patient in the either in the mid scapular line or in the mid axillary line, and then finally we will be doing the aspiration for the diagnostic purpose, that is 20 to 40 ml pleural fluid will be taken. Okay, and after the procedure we should always check the chest x-ray so that we are actually ruling out other things as well, because sometimes it can lead to pneumothorax or it can lead to other kind of trauma in the patient, right, if it is not done properly, let's say. So a post procedure chest x-ray we should always do and we should always check, right. So this is the procedure how we are doing basically. So we are asking the patient to hold this kind of position where the patient is resting his hands on the elevated table, and this kind of position will be taken by the patient, and then we'll be checking the pleural fluid, basically excess amount of pleural fluid, and then we'll mark it, and then we'll drain the fluid. Okay, so around 20 to 40 ml will be drained for the diagnostic purpose, right. So what are the tests which we need to send for actually whichever pleural fluid which we have collected? So first line investigation which should be sent, that is the cell count. In the cell count we are covering the total count and as well as differential count. Then the protein, sugar, ADA. Sugar is also called as glucose. So total count, protein, glucose, ADA, these are the must which we need to send over there. So pleural fluid examination for the diagnosis of pleural tuberculosis. So these are the, so for example, exudate with protein, if it is more than 3 gram per deciliter, then almost all the cases are saying that this is the pleural tuberculosis. If the pleural fluid glucose comes out to be more than 60, then almost around 80 to 85% of the patient a probability is there that the patient is having pleural tuberculosis. If it is more than 50% lymphocyte, then 93.3% chances are there that patient is having tuberculosis, and if the ADA is more than 40 pleural fluid ADA, then also the chances are high that the patient might be having the TB or tuberculosis, right. So what about the cultures? So we'll send the pleural fluid cultures. So solid culture is positive in only about 12 to 30% of the cases, whereas liquid cultures using the MGIT, Mycobacterium growth indicator tube, basically they display the better sensitivity. So liquid culture is having the better sensitivity as compared to the solid culture, that is the take home point from here. And MGIT cultures are also available quickly as compared to the solid cultures. So they are coming within 2 weeks around, and whereas if you talk about the solid cultures, they take around 30 or 40 days, at least a month they will be taking. So obviously the liquid cultures are much better as compared to the solid cultures in the time perspective also, and about the sensitivity as well. Okay, what about the nucleic acid amplification test? That is the NAT test, and as far as NAT test is concerned, for the MTB or RAF, it is having a not a very good sensitivity, that is around 49.5%, but the specificity is very good. That's why we are routinely doing it, the NAT test over here, that is the 98.9%. So they say that if you are having availability of the NAT and NAAT, nucleic acid amplification test, then you should definitely do it. If you don't have availability, then obviously you will not be able to do it. But if you are having availability of doing that in your center, then obviously you should be going ahead with that. So after that, ADA, adenosine deaminase. So ADA level in pleural fluid is a semi-specific biochemical marker, okay, that we need to understand, and it is having a cutoff level of 40, right. So having a very good sensitivity and the specificity as well, around 92% is the sensitivity and specificity is around 90%. So if we talk about this thing, then about the pleural fluid, then we should be sending the protein, glucose, ADA, and the cell count, total count, differential count. Then we should be sending the cultures, we should be sending the NAT, basically NAAT, and we should be sending the adenosine deaminase, that is the ADA, and the culture over there, right? So what is the significance of CT scan in the diagnosis of tuberculosis? So let's say we are not able to we are in some kind of confusion that this patient might be having some kind of pleural thickening also, or we want to confirm that some kind of patient they might be having the other kind of involvement also. For example, pulmonary involvement can be there, the patient may have some other comorbidity, some other disease also. So in that case we can be going ahead with the CT scan as well, but it is not done in the first place itself. So CT scan in the diagnosis of pleural tuberculosis. So what are the findings? Basically we are seeing that there is a hypodense effusion with the pleural enhancement. Okay, there could be the pleural thickening or there could not be the pleural thickening as well. What is the use? Basically when diagnosis is not clear and we are suspecting the malignancy and the HIV positive patient. Okay, advantage is that sensitive, it is more sensitive than the chest X-ray obviously, okay, for checking the primary lung involvement. But disadvantage is that there is a high cost, there is a high radiation exposure, and there is a difficulty in distinguishing the small effusion with the pleural thickening. Okay, so that is the that is also the major point over here. Okay, now so there is a low sensitivity for the septation. For the septations we need to do the ultrasound is showing good septations, not the CT scan and neither the chest X-ray. So difficult to distinguish between the small effusion and the pleural thickening. So that is also the thing over there. Then pleural biopsy, guys, we are having three kinds of pleural biopsy basically. So one is the percutaneous pleural biopsy, where what we are doing is that it is involving the closed pleural biopsy, okay, and CT guided needle biopsy. Simple. So CT guided needle biopsy we can do, that the closed pleural biopsy, so it can be done as blind, or usually it is done ultrasound guided. Then we are having other one, that is the thoracoscopic pleural biopsy. So that these kind of pleural biopsy are useful in the cases who are having a negative percutaneous biopsy, okay, and where we are suspecting that there could be some kind of malignancy or something like that. Then in those cases we shall go ahead with the thoracoscopic pleural biopsy. And then we are not able to find the results, then we shall go for the last one, that is the open biopsy via thoracotomy. That is the surgical option basically. This is the invasive one. So surgical procedure that has largely been supplanted by the above mentioned method. So I mean the first one is the percutaneous pleural biopsy, simple. Second one is the thoracoscopic pleural biopsy. We need to do the thoracoscopy and then take the biopsy. Both rigid or semi-rigid thoracoscope can be used in this case. And then if even then we are not able to find the cause, then we shall go for the surgical option, that is the open biopsy via thoracotomy, right? So how many number of samples we should be getting it over there? So more than 6 biopsy samples should be enough for for the biopsy purpose, right? Then coming to the histopath and the culture. So we did the biopsy once, then we need to send it to the lab further. So histopath with evaluation for the presence of granulomas basically. So for the granulomas purpose, okay, if we are finding the granulomas, then it is having a very good sensitivity, having around 70 to 80% of the sensitivity in diagnosing the TB, while the use of culture in this specimen has sensitivity of 60 to 67%. So here what we can see is that granulomas are having a very high sensitivity in diagnosing TB, whereas use of culture also is having a higher sensitivity, but comparatively obviously the histopath is having a very good sensitivity. Use of the NAT over here. So using NAT on the pleural biopsy specimen, okay, showing the greater result over here, greater sensitivity. So around 45 to 85% chances are there on pleural biopsy if we are running the NAT. So it is increasing the chances for the diagnosis. Specificity is also very good, 97.2%. So we should definitely go for the NAT in the pleural biopsy cases, right? Now if we compare the different modalities for the pleural tuberculosis, then this table is very good to remember actually. So if we talk about the chest X-ray, we should be doing it in all the patients, and we should be looking for the blunting of CP angle, that is the Kostow-Frenning angle, and we shall look for the pulmonary involvement, that is the nodules or the lymph node, to monitor the progress. What about the HIV testing? It is mandatory for all the patient. So whatever TB patient we are seeing, we should be doing the the HIV testing for such patients, right? So due to association of EPTB and HIV, because they are very commonly involved, very common friends basically, so all suspected or the diagnosed patient must undergo the HIV testing as per the national program. So one thing is about this chest radiograph, and second thing about is that we should be doing the HIV testing. CT chest and abdomen, it is not mandatory for every patient, depends on physician view as well about the patient, depends on patient to patient basically. So if we are doing the CT chest, then usually we are doing that in the cases of suspected malignancy with positive patient, and it is more sensitive than the chest X-ray obviously for detection of any kind of pulmonary node or the effusion as well. Then about the USG chest, it is also again selected, can detect the smaller amount of fluid basically, right, and loculation or adhesion fluid thickening can be visualized in this USG chest better. So septations, loculations are better visualized in the USG chest as compared to X-ray or the CT scan. That is the major benefit over here for using the USG chest. Right, about the pleurocentesis, so all the patient must undergo pleurocentesis for getting the diagnosis basically, that what is the diagnosis behind the pleural effusion. So basically we are checking many things, but among those things we will be taking the samples and will send it for the glucose, protein, ADA, LDH with the recurrent serum LDH, so that we can compare the serum LDH and the pleural fluid LDH, and we shall be sending for the differential counts as well. Specific investigations like the microscopy and the culture for MTB and cytology should also be sent over there, right. And usually whenever we are taking the pleural fluid, there is a confusion that is it exudative pleural effusion or is it the transudative pleural effusion. Basically the idea of doing the diagnostic tapping is to get to know about whether it is transudative pleural effusion or the exudative pleural effusion, right. And pleural TB is one of the common cause of exudative pleural effusion, so remember that in mind. What about the ADA levels or the ADA levels? So if it is more than 70, highly suggestive of pleural tuberculosis, less than 40, then low likelihood of TB, investigate for the other causes as well. If it is 40 to 70, then it is indeterminate level, it can be TB or it may not be TB as well. About the sputum samples, in the selected patient only will be sending for the sputum samples where you are suspecting the pleural tuberculosis as well. For example, you can send sputum for the NAT and the microscopy and the culture, right, according to the anti-TB protocol. Then coming to the pleural biopsy is that again we will be doing in the selected patient where we are suspecting the some kind of malignancy or where the thoracoscopy need is there, right. So it is having much higher yield than the pleural fluid for microscopy and culture. Actually thoracoscopically obtained specimens have a higher diagnostic yield, okay. So that is the basic thing over here. We shall also go ahead with the NAT basically. So sensitivity of the NAT is 46.1%, where the specificity is very nice, that is the 99%. So that definitely we should go for the NAT samples as well in our patients, right. Now what about the management part? In the management part, we will be going for our beautiful regime, that is the anti-tubercular therapy, that is the 2-HRZD. 2-HRZD means isoniazid, rifampicin, pyrazinamide and ethambutol plus 4-HRE. 2-HRZD means for 2 months we will be going for the intensive phase, that is the HRZD regime, and then after that from the 3rd month itself onwards we will be continuing the 4-HRE, that is the for the 4 months we will be going for the isoniazid, rifampicin and the ethambutol. We will not be using the pyrazinamide, right. So basically mostly in most of the cases we are seeing the clinical improvement that is seen in around 2 weeks, right. So like patient will be start gaining the weight, basically the patient appetite will be improved, the patient cough and symptoms will be improved. So these kind of changes which we can see in the patient. So follow up chest X-ray we should be always doing after 8 weeks, so that we can compare the disease progression, we can compare the pleural fluid progression, basically whether it is decreasing or not, or whether it is increased or not. So these kind of things should be done. So about the treatment, we should be giving the ATT obviously, then pleural fluid drainage we should be done, we should be going ahead with the testing for the HIV, that is very important. What about the complications over here? So sometimes we are seeing that the patients are having the lack of response. In some of the patients, around 15-20% of the patient may have the lack of response from the patient side. So there we shall be having the trouble of immune reconstitution inflammatory syndrome. So what happens is that after once patient will be starting the ATT therapy, so they are getting more and more amount of immunity. So when this immune activity from suppression state, it will be coming to the active state, then in some patient there could be the hyper reactivity basically. So immune reconstitution inflammatory syndrome, which we are calling that. In some patient there could be the drug resistance, right, where we shall consider the MDR TB, is it there or not, we need to confirm that. Then the alternate diagnosis which we need to look for, that yes, this patient is not responding to my treatment, I have given my ATT for around 2 weeks, still there is no effect and all, then we should be looking for the other diagnosis as well in our mind. Then there could be some superadded infection. So if the patient usually the patient immunity is already low, and if some other infection will catch this patient, then also the patient might not be showing the good recovery. Next case is the pleural thickening is a very common complication. If the pleural fluid is there for a very long period of time in the pleural space, then it can cause the thickening of the pleura basically. And then there in some patient we shall see the empyema also, where there is a pus in the pleural space or the pleural cavity, and we shall also be seeing in some cases the hydropneumothorax, where the water is also there, fluid is also there in the pleural cavity, and with that there could be the air as well, that is the hydropneumothorax. So once again let's just see this particular flow chart over here. There is a pleural TB flow chart, very good flow chart which is given over here. So while taking the history of the patient, if you are finding these kind of symptoms like acute or chronic onset cough, there is a chest pain, there is a fever, low or high grade fever might be there is a SOB, weight loss, loss of appetite, night sweats, then what do you think about that? So in this patient we shall be thinking about the pleural effusion. So we should always rule out the effusion over here. While doing the percussion, you will be hearing the stony dull note on the percussion, okay, and while auscultating the patient, you will not be hearing much sound over there. So there is a diminished breath sound or the decreased breath sounds. After that, if you are having this kind of patient, then what you need to do next? So next we should be going for the chest X-ray, which is a mandatory for all the patient, HIV testing, which is mandatory for all the patient, but HIV testing comes when you are sure about the TB. For now, patient comes to your emergency and you want to run some test. So these are some tests which you can go for. Go ahead with CBC, LFT, KFT, and then there is a PT-INR, right? Why PT-INR we are sending? Because if we need to prick this patient in the future, then the coagulation profile should be okay, right? So we should be doing the chest X-ray, we should be doing the ultrasound if it is available in your center, and then there is a CT scan. CT scan comes in the last one. So that is the thing. So CT scan will be needed only when we are suspecting some kind of pleural malignancy or something like that. Now if we talk about the radiology, so here we are doing the ultrasound, okay, here this is a picture of USG, right, where they are trying to find out that where is the effusion, okay, and probably this one is the liver border, which we can see over here, and this is the anechoic region in the ultrasound, basically that could be the pleural fluid, excess amount of pleural fluid, okay. Now so you should be I have talked about this earlier as well, you should be ruling out that platelet should not be lesser than 50,000, INR should not be more than 2, or these kind of things which we need to keep in mind as well. So diagnostic pleural tap, after that, so pleural effusion which is diagnosed radiologically, then we should be going for the diagnostic pleural tap, because we want to send this pleural fluid for the microbiology examination as well. So pleural fluid which will be actually sending it for total count, differential count, glucose, protein, ADS cytology, we have already talked about that. For chronically suspected cases, bacterial and the fungal cultures may also be sent as well, okay. Then coming to the main point over here, that you are having the pleural fluid report as well, you are having the serum report as well, right. How to know that whether it is exudative or transudative? So we are having a light criteria, that is the very popular criteria, that is the light criteria. In the light criteria, what we are seeing is that, okay, so let's talk about the light criteria, okay. So just a second over here, yeah. So let's talk about the light criteria, that what is the light criteria. So in the light criteria, basically they are saying that, okay, just a sec. Yeah. So light criteria, they are saying that this is the light criteria. So pleural fluid protein by serum protein if it is more than 0.5, or pleural fluid LDH by serum LDH if it is more than 0.6, or pleural fluid LDH more than 2/3 upper normal range of serum value, then this is the exudative. Otherwise it is the transudative. So if it is yes, then it is exudative. If it is no, then this is the transudative. Next thing over here is, if it is exudative, then you should be thinking of that it could be the pleural tuberculosis as well, because pleural tuberculosis is one of the major cause of exudative pleural effusion. So here tubercular pleural effusion, so here basically if you are finding that it is the exudative, the next step is that you will be doing the radiological scans over there, suspected pleural TB with lymphocyte predominant exudate. So you will be doing the fluorosynthesis, you will be sending the samples to the microbiology lab, and in that case you saw the counts over there. If it is lymphocyte predominant and ADA is more than 40, then probably it is the tuberculosis, right? It is the tuberculosis. Start the anti-tubercular treatment drugs, ATT, right? So if it is tubercular pleural effusion, you can start with the tuberculosis, you can start with the ATT drugs, right? Let's say after doing the fluorosynthesis, you did not find the lymphocyte count high, or you did not find the ADA count is high, these both are low, then in that case, still because you are suspecting clinically that there is a, clinically and radiologically you are suspecting that there is a TB, but you are not getting confirmation from the labs, still there is a doubt for the tuberculosis. So in that case we shall go for the CT scan. In that case we shall go for the CT scan and the biopsy, right? Okay, and after taking the biopsy, what are the samples which we need to send for? AFB, gene expert, histopath and the NGIT. So these are the samples. Now if it is not the if the suspicion of the tuberculosis is not there, then you should be finding out the other causes as well. Okay, now let's say that you did the pleural pleural fluid examination and you found out that there is a gene expert positive, right? Then obviously you should be going ahead with the anti-tubercular treatment drugs. Okay, so that is also very important. Fine. Let's come to this table over here. Okay, this is also a very important table and very good one actually. So this is the just summary of the pleural tuberculosis, what we have just actually talked about. So if the patient is coming to you with having this kind of history, that the patient is talking about the fever, there is a pleuritic chest pain, cough, breathlessness, anorexia, weight loss, night sweats, or history of TB contact, then obviously we should be thinking in the line of tuberculosis. Examination, that you will be auscultating the patient, percussing the patient. In the percussion there will be the stony dull note, on the auscultation there will be the decreased or diminished breathing sounds over there, right? So this is the thing. Then investigations over here, what we can do, basically chest x-ray is mandatory, which should be done in all the patients. Then in some cases if you are suspecting the pleural TB also, then you can actually go for the sputum, AFB and NAT. Okay, you can send it that as well. Then we should be doing the thoracynthesis, that is the usually nowadays we are doing the ultrasound guided thoracynthesis, and after doing thoracynthesis or fluorosynthesis we should be taking the pleural fluid sample and we should send it for the, basically this is very important, so we should send it for the cell count. Okay, cell count, the protein, right? So these are the things. Yeah, so we should be send it for the cell count, protein, glucose, gram stain, culture, bacterial culture, then the stain for AFB, ADA, NAT, cytology. Okay, so nothing should be left over here. We should be checking these things. Now if desirable, then we shall go for the CT chest, otherwise not. CT chest is not mandatory for all the patient over there, right? Okay, fine. Now let's say there is a case of pleural effusion, right? You will be doing what? You will be doing the sputum examination and the thoracynthesis, right? Let's say there is some there could be the chance that there could be alternative etiology, there could be transudative, there could be exudative, or there could be some malignancy as well. You need to treat them accordingly. But let's say sputum or pleural fluid you did and they are positive for AFB or the NAT, straight away you can start the ATT treatment. But if it is negative, then you will go for the ADA. So first of all, you check the pleural effusion, you did the thoracentesis. After the thoracentesis, you will be sending the pleural fluid for AFB, NAT, along with that other things, cell count, protein, LDH, okay, all those things. Then if the sputum, if the pleural fluid AFB or NAT is positive, or the sputum or pleural fluid AFB or NAT is positive, straight away go with the anti-tubercular treatment drugs. Straight away you can start. If it is not, then you can go with the ADA. So ADA levels will check. If it is less than 40, then the results are still inconclusive. In that case, we need to do the pleural biopsy. Okay, in that case, we need to do the pleural biopsy. If the ADA is between the 40 to 69 or 40 to 70, then usually we are saying that 20 to 40 years is the main general age group which we are seeing basically. So age, if it is less than 40 years and patient is having the fever, patient is non-smoker, etc., yes, you can start the anti-tuberculosis therapy over here. If there would be no response in 4 weeks around like that, then we shall go for the pleural biopsy. If let's say the ADA is more than 70, then this is the clear-cut case of the tuberculosis. So you should start the anti-tubercular treatment drugs from now on, right? Okay, so that is the thing over here. Now we should know when to refer. So if in your facility ultrasound assistance is not available, then obviously you should refer this patient to the other center. If the diagnosis is not established after thoracentesis and facilities for pleural biopsy is not available, then you shall refer this patient for the pleural biopsy further in some other hospital. Drug resistant TB is detected according to NTEP guidelines, right? So if patient is not responding to your treatment, you should keep one differential diagnosis in your mind, that patient might be having resistant to your current treatment regime, right? So drug resistant TB can also be there, right? So worsening pleural effusion on follow up, then also the patient is getting bad, it means you should refer this patient if you don't have much facilities at your hospital. Okay, so that is the thing about the tuberculosis basically. Okay, and obviously we need to follow up our patient regularly basically. So many patients who respond to treatment will have improvement by 2 weeks over there and significant improvement by 4 to 8 weeks, right? A follow up chest x-ray should be done at 4 to 8 weeks after starting ATT over there. Okay, so that we shall know about the prognosis over there, right? So I think you must have understood the basic idea of the pleural tuberculosis, that how we are making the diagnosis, how we are suspecting the diagnosis of the pleural TB, and how we are reaching to the conclusive diagnosis of the pleural tuberculosis and then further management. So that's it about the pleural tuberculosis. I hope you got some value out of this video. If you did, then please hit the like button and share it with your friends. I will see you in some next video with some other interesting topic. Thank you.